Hello class and welcome to week 2. Today we will be briefly covering concepts of the shoulder girdle and the glenohumeral joint. The bones of interest are the scapula and the clavicle, but the manubrium, shown here, also plays a role as a point of attachment for ligaments, specifically when we're discussing the SC joint, the sternoclavicular joint. The SC joint has 15 degrees of movement anteriorly and posteriorly with shoulder protraction and retraction respectively. There is also slight rotation of the clavicle during shoulder flexion. Now the AC joint has about 20 to 30 degrees of gliding and rotational motion during shoulder flexion, abduction, and other movements. Finally, the scapulothoracic junction is not a true joint, but it does have movement across the posterior rib cage. There's 25 degrees of abduction and adduction, 60 degrees of upward and downward rotation, and 55 degrees of elevation and depression of the scapula. Here are the major ligaments of the shoulder girdle, and they help support and stabilize each of these joints. Looking at this illustration here, we see that the AC ligament keeps together the acromion process and the clavicle. Anytime there is an AC joint sprain or a shoulder separation, you can see why the distal end of the clavicle will sit superiorly. There's nothing really holding it down, so it'll look like it's popping up. Here are the 6 primary movements of the shoulder girdle. As you can see, each movement focuses primarily on how the scapula moves, but it is important to note that the clavicle will also move wherever the scapula moves. Therefore, the pivot point for all these movements begins at the SC joint. And all these movements may seem unimportant because we rarely have a specific goal that we're trying to accomplish with these movements. But anytime you have to move your arm, elbow, wrist, hand, if you're trying to reach overhead or anything like that, it is critical for these shoulder girdle movements to be working correctly. The 5 primary muscles of the shoulder girdle include the pectoralis minor, serratus anterior, trapezius, the rhomboid group, and the levator scapulae. All these muscles have their origin on the axial skeleton, and if you remember that from your terms in the first week, axial skeleton refers to mainly the spine. So they all originate there, and they insert on either the scapula and or the clavicle. An important point here is that these 5 muscles are critical dynamic stabilizers of the scapula. So anytime you have a throwing or blocking motion, the scapula has to be stabilized and these muscles perform that duty. But they're also very important in just posture. So in most of our general population, most people have forward shoulders or rounded shoulders. And that means that they have strong protractors and weak retractors. So essentially the muscles posteriorly are a little bit too weak. They're not really pulling back on the scapula and keeping your shoulders a little bit more straight. This table found in your textbook breaks down each agnus muscle, including their function and how to palpate it, which is really useful. For example, the pec minor originates in ribs 3 to 5, and it inserts at the coracoid process. It abducts, downward rotates, and depresses the scapula. Now to palpate it, it kind of gives you a description of how to do that. In clinic, we usually have the patient lie supine, put their arm or their hand behind their head, and this kind of exposes the pectoralis major, which then allows the clinician to kind of grab the pectoralis tendon and pull it upwards, and then you can use your other hand to kind of dig under there and find the pectoralis minor. However, this could be really painful for the patient. Another interesting point is that as you start looking at the actions of all these muscles and grouping them together, you can see that you can get creative in how you want to treat your patients because, for example, talking about people that have rounded shoulders, if you look at rhomboids, they adduct the scapula. So this is one muscle that you'd probably be really interested in strengthening to make sure that their shoulders would be pulled back a little bit better. Moving on to the shoulder joint or glenohumeral joint, These are the bones that are involved, which includes the scapula, the clavicle, and the humerus. Some interesting points, or an interesting point to make here. We are kind of studying the shoulder joint and the shoulder girdle separately, but here I can tell you this is how they work together. The shoulder joint performs shoulder abduction in the range of about 90 to 100 degrees, so about shoulder height. You can lift your arm about shoulder height just using the shoulder joint. But if you wanted to reach all the way above your head, like to reach something, you would need the assistance of the shoulder girdle, because the shoulder girdle is the one that the muscles involved there upwardly rotate the scapula about 60 degrees. And that's the only way that could happen, because otherwise the humeral head bumps into the acromion process. As for the stability of the shoulder joint, we have these ligaments specific to the GH joint and the humerus. And along with the glenoid labrum and joint capsule, they provide some stability. But because of the wide range of motion of the GH joint, there's still a great risk for injury. For example, shoulder dislocations frequently involve damage to a portion or all of the glenohumeral ligament, and also the labrum. And after initial dislocations, patients will be more predisposed to subsequent dislocations, because those structures, the ligament and the labrum, they're not going to be as tight. They're not going to provide as much stability in a joint that already has a lot of laxity. Here's the ranges of motion for the shoulder joint, and you're going to explore this a little bit more in your textbook and your notes, and what muscles contribute to these motions. And just to kind of give you a little overview of that, here are the primary muscles that cause these motions. And as you start learning these actions, you also start grouping them by those actions. However, to make sure that you're reading the specific details of each of the muscles, because you're going to find some key notes there. For example, the supraspinatus, its action is abduction, but so is the posterior and middle fibers of the deltoid muscle. Now, when we look at this illustration here, here's the supraspinatus, here's the deltoid. The deltoid is much more thicker, larger muscle than the supraspinatus. So whenever you have to abduct your arm, you're probably going to rely more on the deltoid than the supraspinatus. However, the supraspinatus, more importantly, one of its major functions is just to hold the humeral head in the glenoid fossa, which is really important as a dynamic stabilizer. Finally, I want to show you a few video clips of a shoulder exam. I thought this would bring together everything you've been learning up to this point. The material here is advanced. Not too advanced, but Dr. Hutchinson does a pretty good job of simplifying it and making it relevant. And also it highlights the importance and usefulness of knowing your anatomy. Here's the first clip, and notice how Dr. Hutchinson intentionally uses directions and specific landmarks to describe what he's observing and palpating.
Look at for this young man from the front is to see if his pectoralis size is the same on both sides. We want to see if his shoulders are at the same elevation. He's not drooped on one side compared to the other. And then from the front, we can palpate certain parts of the anatomy. So we can palpate along the entire clavicle, from the sternoclavicular joint, along the clavicle itself, down to the AC joint. Just below the AC joint is the coracoid process, which is where the biceps tendon, or one of the two heads of the biceps, attaches. We follow straight down towards the axillary crease. If we put our fingers directly into that area and roll our fingers, you can actually roll right along the biceps tendon. At the anterior axillary fold is actually part of the pec tendon, and as we abduct and we have him resist pulling in, the pec tightens and you can actually palpate along the pectoralis tendon.
This next clip demonstrates how the quality of range of motion is evaluated. Dr. Hutchinson separates the movement of the glenohumeral joint and the shoulder girdle.
Range of motion. And when we evaluate range of motion, we want to do it actively, which is just what the patient's going to do, as well as passively to try to isolate ball and socket versus the ball and socket and shoulder motion. So actively, we're going to have him bring his arms forward flexed, bring your arms up over your head as high as they go. And here he's able to forward flex about 180 degrees. Please bring them back down. We're going to have him bring them up sideways, out to the sides, all the way up over his head. So his abduction, again, comes up about 180 degrees, back down. We'll have him put his arms abducted 90 degrees here. So he's now internally rotated, then externally rotate. So he externally rotates about 90 degrees, and internally rotates 90 degrees, and then back down. Put your hands down.
So if you remember, as I previously mentioned, all the GH joint movements occur below 90 degrees. So here he's going to kind of help you understand how you can stabilize the scapula to do this.
We want to try to isolate the ball and socket motion. And to do this, we always have to stabilize the scapula to just see what motion we're getting in the glenohumeral joint. So I'm going to have you rotate a little sideways, if you will. Perfect. And so with the shoulder the scapula stabilized, now I'm going to abduct his arm passively, and I can bring him up to maybe 90 to 100 degrees. The moment I feel his shoulder blade move, that's when I'll say that his true glenohumeral motion is stopped. Forward flexion, same thing, maybe about 120 degrees. With his arm abducted, shoulder stabilized, he has about 45 to 50 degrees of internal rotation. External rotation, maybe 80 to 90 degrees.
Finally, in this clip, Dr. Hutchinson is evaluating scapular dyskinesia, which is the improper control of the scapula.
Scapular dyskinesia if the muscles are actually discoordinated or not working properly. So looking from the back, what we want to see is general position of the shoulder to make sure that he's symmetric on both sides. One's not elevated, his shoulder is not winged. And then we'll do about 4 different movements to try to exacerbate abnormal motion in his shoulder. So shrug your shoulders backwards, forwards, up, and down. And for this young man, as we watch him go backwards, shrug your shoulders backwards, you can see this shoulder actually elevates slightly higher than the other side. So he has a mild degree of scapular dyskinesia in this position.
So the cause of the shoulder elevation is probably due to overactive upper trapezius and the levator scapulae. And so these are the type of things that you can address with your patients when you know origins and insertions and the movements of certain muscles and how to test those ranges of motion. All right, that's it for today. Thank you for watching. And as always, if you have questions or want to further discuss any of the topics covered today, you may always reach out to me. Thanks and have a great week.